Hello everyone, I am myself Dr. Rajesh Gubba. I am the general medicine educator. So in this session, I'll be discussing the previous year questions in UPSC on the topic of the rheumatology. So it is not just only the previous year questions, I'll also be discussing about the entire topic of that particular previous year question. So in the rheumatology, mainly the questions have been concentrated on the rheumatoid arthritis, that is one important topic. Second important topic is ankylosing spondylitis, and third important topic is the vasculitis. Like we have small vessel, large vessel, and as well as medium vessel vasculitis. So on these three topics, mainly the questions have been asked. So I'll be discussing these three topics in detail, which will be useful even for your upcoming UPSC exam as well, right? So now if you see the first question, which of the following are correct with regard to the ankylosing spondylitis? The options are: bamboo spine may be seen, early morning backache pain is rare, uveitis is the most common extra-articular feature, it is more common in males. Select the correct answer using the code given below, right? So first and foremost, the bamboo spine, it is definitely seen. Second point, early morning back pain is a rare, it is an incorrect statement. So usually you have the early morning back pain in patients with the ankylosing spondylitis. And uveitis, yes, the uveitis is the most common extra-articular manifestation. And it is not just only uveitis, there are many other extra-articular manifestation in ankylosing spondylitis, which I'll be discussing that in detail. And that too, the type of the type of uveitis that you will be having is the anterior uveitis. So the anterior uveitis, it is very common, right? And this is more common in males rather than females. So what will be the answer now? It is 1, 3 and as well as 4. Now, if you see the basic definition of the ankylosing spondylitis, this is one of the chronic inflammatory disease of the joints. Right, so it is the chronic inflammatory disease of the joints. Now, which particular joints are commonly affected? It is mainly the axial skeleton, right? And what will be that axial skeleton? That is, you have the involvement of the spine and as well as the involvement of the sacroiliac joint. Okay, involvement of the spine and as well as the involvement of the sacroiliac joint. So the involvement of the spine, you will have the progressive stiffness of the spine, right? You have the progressive stiffness of the spine, and this progressive stiffness of the spine, this is commonly observed first where it will start. So it is the lumbosacral spine which is affected first, right? It is the lumbosacral spine which is affected first. And gradually you have the involvement of the thoracic spine, and gradually there will be involvement of the cervical spine. So the last to be affected will be the cervical spine. And what is the age of presentation of these patients with ankylosing spondylitis? That is around 20 years. And the incidence of ankylosing spondylitis, this is more common in males rather than females. And this ankylosing spondylitis, this comes under what is called as the seronegative arthritis. So seronegative arthritis in the sense where the RA factor is negative, right? So the RA factor, it is negative. Okay, now the seronegative arthritis, like we have many examples. It is not just only the ankylosing spondylitis. Now what are the examples of the seronegative arthritis, right? The mnemonic is, please remember this mnemonic, that is PAIR. The word P stands for psoriasis. The word A is ankylosing spondylitis. The word I, it is the inflammatory bowel disease. The word R, it is the Rheumatoid syndrome, right? So, or this is reactive arthritis. Okay, so Rheumatoid syndrome or the reactive arthritis. So these are all the seronegative spondyloarthropathies, right? And in this, the RA factor will be negative. Now, to call it as the ankylosing spondylitis, you have certain important criteria. What is that? Number one, there should be sacroiliitis on imaging. And so sacroiliitis on imaging, so that is on the X-ray, right? Or it should be on the MRI. Along with that, there should be more than one spondyloarthropathy feature. This is one part of the criteria. Sacroiliitis on imaging with more than one spondyloarthropathy feature, right? Or the patient should be having the HLA-B27 positive, right? HLA-B27 positive. Along with that, there should be more than two spondyloarthropathy features, right? Along with that, there should be more than two spondyloarthropathy features. So this will be the criteria for the ankylosing spondylitis. Now the question comes, what are these spondyloarthropathy features? Okay. So if you see the spondyloarthropathy features, right, these are all the spondyloarthropathy features, and I have just made a mnemonic for that. So A stands for arthritis, B stands for the B27, that is HLA-B27 being positive, C stands for the C-reactive protein being positive, D stands for dactylitis, right, where you have the inflammation of the joints within the fingers, that is what is called dactylitis, and E stands for enthesitis. So enthesitis is like where you have the inflammation of the tendon over the insertion on the bone or the joint is what is called as the enthesitis. And F stands for the family history of spondyloarthropathies, and G stands for these patients, they have a good response to the NSAIDs, that is non-steroidal anti-inflammatory drugs, and the word I, it is the inflammatory back pain, right? The word I stands for the inflammatory back pain, and P is the psoriasis. So now to call it as the ankylosing spondylitis, what you have to remember here, there should be sacroiliitis on imaging, along with that more than one spondyloarthropathy feature, whatever I have just discussed. Or if it is HLA-B27 being positive, there should be more than two spondyloarthropathy features that should be positive, right? So in ankylosing spondylitis, two important structures. One is you have the involvement of the spine. So in case of the ankylosing spondylitis, the spine, the intervertebral discs and as well as the edges of the vertebra, they are inflamed and they are fused. And when you do an X-ray of the spine, it appears like a bamboo, right? And that is the reason why it is being described as the bamboo spine, and that is due to the fusion of the vertebra. And another important structure which is affected very commonly in ankylosing spondylitis is sacroiliac joint, and because of this, these patients will have very severe low back pain because of the sacroiliitis and as well as the involvement of the lumbosacral spine. And even you take the chest expansion in these individuals, so there will be like kyphosis where there will be forward bending of the spine. So the chest expansion, it is reduced in these patients, and because the chest expansion is reduced in these patients, so these patients will have the restrictive type of the lung diseases. So this will be like the bony involvement or the articular involvement in patients with ankylosing spondylitis. And in patients with ankylosing spondylitis, so the vertebra, like they are fused. Because the vertebra are being fused, what will happen to the flexion movement in the spine? Right? The flexion movement in the spine, it is restricted. Right? Flexion movement in the spine is restricted. So now how is that? You will be able to assess the flexion movement in the spine is, that is by the Schober's test. Right? So that is by the Schober's test. Now how is that you will demonstrate this Schober's test is, like initially you have to draw a baseline, and that should be corresponding to the posterior superior iliac spine, and exactly 10 centimeters above you need to draw one more line, and exactly 5 centimeters below you need to draw another line, right? So if you take the distance between the upper mark and as well as the lower mark, so how much is that? That is like 15 centimeters. Now you ask the individual to flex the spine as much as possible. Right? You ask the individual to flex the spine as much as possible so that he will be able to touch the toe with the fingers, right? That is with the hand fingers. And now you just measure the distance between the upper mark and as well as the lower mark. Now, in a normal individual, right? In a normal individual, the distance between the upper mark and as well as lower mark, it should increase by more than 5 centimeters, right? That means how much should be the distance between the upper mark and lower mark? It should be more than 20 centimeters, right? Whereas in ankylosing spondylitis, like what will happen is, because of the fusion of the vertebra, the increase in the distance between the upper mark and lower mark will be less than 5 centimeters. So that is the reason why after doing the maximum flexion of the spine, when you measure the distance between the upper mark and lower mark, it should be less than 20 centimeters. Right? It should be less than 20 centimeters. Okay. So this is about like the 𝐒𝐲𝐵𝐻 test. So 𝐒𝐲𝐵𝐻 test is the one which will be able to demonstrate the stiffness within the spine. Stiffness within the spine, right? Now, followed by that, you take the extra-articular manifestations in patients with the ankylosing spondylitis. So if you take the extra-articular manifestations, the most common extra-articular manifestations already I have discussed, that is the anterior uveitis. Right, that is the anterior uveitis. Okay, that is one important thing. Second is, you have the involvement of the lung, you have the involvement of the heart, you have the involvement of the spine, you have the involvement of the skin. So you take the involvement of the lung. Involvement of the lung, that will be in the form of the upper lobe fibrosis. Right, so thereby these patients will have what is called as the restrictive pattern in the pulmonary function test. Then you take the cardiovascular system manifestations. The cardiovascular system manifestations include the development of the AR, that is aortic regurgitation, then ischemic heart diseases, right? Then followed by that third degree AV block. Right, third degree AV block. Okay, so these are the cardiovascular system manifestations. And if you take the involvement of the spine, that will be in the form of like what is called as the 𝐒𝐫𝐢𝐻𝐫𝐢𝐻 syndrome. Right, the 𝐒𝐫𝐢𝐻𝐫𝐢𝐻 syndrome. Okay, and what will be the skin involvement? The skin involvement will be in the form of the psoriasis. The skin involvement will be in the form of the psoriasis. So this will be the extra-articular manifestations. And the point here is, what would be the cause of death in patients with the ankylosing spondylitis? The cause of death in patients with ankylosing spondylitis, that will be due to the fracture of a rigid osteoporotic spine. Right, the fracture of the rigid osteoporotic spine, that will be the cause of death in patients with the ankylosing spondylitis, right? Then how is that you will evaluate these individuals is, one is by imaging and the other one is the HLA. So these patients will have the HLA-B27 being positive. That is one of the very important point. But the HLA-B27 is being positive in many other clinical conditions, and these patients, it's an inflammatory condition, so your ESR and as well as the CRP is also elevated. Then how is that you will assess the severity of the ankylosing spondylitis? What is the marker which will tell you the severity of the ankylosing spondylitis? So the severity of the ankylosing spondylitis, that can be demonstrated by an important marker, that is serum matrix metalloproteinase levels. Right, serum matrix metalloproteinase levels. So this is the marker which will help us to assess the disease severity, right? And the next important is, in patients with the ankylosing spondylitis, the RA factor will be negative, and when you do an imaging, so the X-ray of the spine, that will show you the bamboo spine, and that is due to the fusion of the vertebra, and so it is appearing similar to that of a bamboo stick. That is why it is called bamboo spine. And the next important is, due to ossification of the supraspinous and interspinous ligaments, you will notice that there is an important sign called dagger sign. Dagger sign and bamboo spine, these are the two important imaging findings. And not only that, this is the normal sacroiliac joint, right? So this is the normal sacroiliac joint, but when the sacroiliac joint is like completely inflamed and destroyed in patients with ankylosing spondylitis, this is how it will observe, right? This is how it is seen. So you will not be able to make out that sacroiliac junction. Now, coming to the treatment in patients with the ankylosing spondylitis. So what is the first line treatment of the ankylosing spondylitis? The drug of choice will be indomethacin. Right? The drug of choice will be indomethacin. Okay? That will be the drug of choice in patients with the ankylosing spondylitis. That is NSAID. Now, NSAIDs, they are considered as, or they remain, the first line treatment of the ankylosing spondylitis, right? And this will slow the radiographic progression of the spinal disease, right? These particular NSAIDs will slow the radiographic progression of the spinal disease. Now, the next important is, now if the individual is not responding to the NSAIDs, then in them you need to give the TNF inhibitors. So this TNF inhibitors, they have established efficacy mainly for NSAID resistant axial disease, right? So in those individuals who are refractory to the NSAIDs, in them we give the TNF inhibitors. Then we have the new molecules, that is interleukin A 17 inhibitors, 17A inhibitors. Example of these interleukin 17A inhibitors are, number 1, 𝗑𝐶𝐬𝐜𝐫, right? And another important molecule is 𝗑𝐳𝐶𝐬𝐫. So these are the two important molecules, that is interleukin 17A inhibitors. So these two drugs, that is 𝗑𝐶𝐬𝐜𝐫 and as well as the 𝗑𝐳𝐶𝐬𝐫, they inhibit this important pro-inflammatory cytokine, right? They inhibit the important pro-inflammatory cytokine. What is the example, or what is that pro-inflammatory cytokine that is being inhibited by these two molecules? That is interleukin 17A is inhibited, right? And it is also highly effective in the treatment of the ankylosing spondylitis. Next is there any role of the corticosteroids? Corticosteroids, they have minimal impact on the arthritis, right? It has a very minimal impact on the arthritis, particularly the ankylosing spondylitis, right? And these corticosteroids, they even will worsen the osteopenia in case of the ankylosing spondylitis. So that is the reason why corticosteroids are not given. So this is about quick revision of the entire topic, that is ankylosing spondylitis, right? Now, after having discussed about the ankylosing spondylitis, the next important part of the discussion is on the rheumatoid arthritis. Which of the following can be used to monitor the disease activity in rheumatoid arthritis? That is pain, that is visual analog scale, X-ray of the hands and wrist, DAS28 score, and then the ESR. So please remember, we use the pain, that is X-ray analog score, to assess the or to monitor the disease activity, but not the X-ray of the hands and wrist. And we also use DAS28 score. What exactly is that, I'll tell you. And then we also use the ESR, because rheumatoid arthritis is an inflammatory disease, so the ESR, it will be increased in these patients. Now you take one by one. That is pain visual analog score or scale. This is the tool used to measure the patient's pain level, right? So this is the tool used to measure the patient's pain level. Since pain is a major symptom of the rheumatoid arthritis, monitoring the pain using visual analog scale, it will help us in assessing the disease activity and as well as the effectiveness of the treatment. That is about the pain. So pain, definitely it is one of the very important parameter which will monitor the disease activity. Second important is the X-ray of the hands and as well as the wrist. X-rays, it can show that there is joint damage, right? And the joint damage will also progress over the time. But these X-rays, they are not useful for monitoring the real-time disease activity. Okay, so X-ray will show you that there is a damage, but this will not, right? This will not assess the real-time disease activity. Okay, so that is about the X-ray of the hands and wrist. Next, DAS 28 score. So what do you mean by the word DAS? Disease activity score, right? DAS stands for disease activity score. So this DAS 28 score, it is a composite index that includes, what are all there in this? It's a composite index that includes the number of, right? It includes the number of tender and swollen joints, right? It includes the number of tender and the swollen joints. Okay, so like the score is calculated out of 28, right? The score is calculated out of the total of the 28. Okay, so this DAS 28 score, it is useful to monitor the disease activity in rheumatoid arthritis, right? Then you take the ESR and as well as the CRP. These two are the markers of the inflammation, right? These two are the markers of the inflammation. So they are useful to monitor the disease activity. So they are the indicators of the disease activity. ESR and CRP, when it is elevated, that tells you that it is a severe form of the rheumatoid arthritis, right? So the correct answer is what now? The correct answer is your 1, 3 and 4, right? Now, to just give you a brief discussion related to the rheumatoid arthritis, this is an autoimmune disorder. This is more commonly observed in females rather than males. It is having an HLA association, that is HLA-DR4 association, and the joints which are commonly affected are mainly the small joints, and within the small joints, the joints which are commonly affected are the metacarpophalangeal joints. Then you have the involvement of proximal interphalangeal joints and even the MTP, that is metatarsophalangeal joints. But please remember, the DIP, that is distal interphalangeal joints, in case of rheumatoid arthritis, they are spared. They are not affected. Distal interphalangeal joints are not affected in these individuals. That's a very important point, right? And what is the clinical conditions where you have DIP involvement? You have that in case of the osteoarthritis, right? And you have that in case of the psoriatic arthritis, right? But not in case of the rheumatoid arthritis. Then next important is, apart from these joints, small joints, you also have the involvement of the spine. But which part of the spine is commonly affected is the cervical spine is affected. Now, because of the involvement of the joints and spine, what will be the clinical manifestations? So because of the involvement of these small joints, these patients, they complain of the morning stiffness. Right, these patients, they complain of the early morning stiffness will be there, and this early morning stiffness will be there for more than 1 hour. And the joint involvement, if you observe, it is symmetrical joint involvement, right? It is symmetrical, bilaterally symmetrical joint involvement. That is what you observe in case of the rheumatoid arthritis. And due to the involvement of the cervical spine, there is dislocation of the C1 and as well as C2. Right, so there is atlantoaxial dislocation, and because of atlantoaxial dislocation, what will be the presentation of these patients is they present with what is called as spastic quadriparesis. right? So they present with what is called spastic quadriparesis. So that will be the presentation in case of the cervical spine involvement, that is C1 and C2 dislocation, right? Then after the involvement of the spine, you need to understand that these patients, they also have the extra-articular involvement. Or before going on to the discussion of the extra-articular involvement, these patients with rheumatoid arthritis in long term, if they are not being treated, they develop deformities. What are these deformities? These deformities, like we have the following. One is the swan neck deformity. The other one is the boutonniere's deformity, or this is called as the buttonhole deformity. Then next important is the ulnar deviation, right? Next important is the ulnar deviation. Then followed by that, if you take the thumb, Z-shaped thumb, right? Z-shaped thumb. So this will be the deformities. Now let me try to show you these deformities, right? So this is your boutonniere's or buttonhole deformity, and this will be the swan neck deformity. Now, where exactly will be the abnormality within the joints? So in swan neck deformity, it is in the proximal interphalangeal joint. You have the hyperextension, right? You have the hyperextension at the proximal interphalangeal joint, and distal interphalangeal joint, you have the flexion. Okay, so hyperextension at the level of PIP, and there will be flexion at the level of the DIP. That is what you will observe in case of swan neck. And exactly opposite is what you will observe in boutonniere's or the buttonhole deformity. So in boutonniere's or buttonhole deformity, you will have flexion at the PIP, and you have the extension at the DIP, right? Then apart from these two, so yes, so this will be the Z-shaped thumb, right? And the very important differential diagnosis for the swan neck deformity is the mallet finger deformity. In mallet finger deformity is not observed in rheumatoid arthritis. Mallet finger deformity is the one which is usually observed in trauma, right? Where there is a rupture of the tendon which is inserting over the distal phalanx. So thereby you will notice that there will be flexion of the distal interphalangeal joint. Whereas proximal interphalangeal joint, it is absolutely normal, right? The proximal interphalangeal joint, it will be absolutely normal. But whereas the distal interphalangeal joint, you will observe that there is flexion. Okay, and that is due to rupture of the extensor tendon which is inserted over the distal phalanx. Okay, so this is about the mallet finger deformity, and this is the ulnar deviation observed in rheumatoid arthritis. And you will have the atlantoaxial dislocation, where you have C1 and C2 vertebral dislocation causing the spastic quadriparesis. And the classical clinical presentation of these patients is, right, they present with actually pain in the occiput, right? So they complain of pain in the occiput, right? And that will be radiating up to the cervical spine. And along with that, on examination, you have the presence of the spastic quadriparesis. And how will you diagnose the atlantoaxial dislocation is, you need to take the X-ray of the cervical spine. And the X-ray of the cervical spine, you have to take it in both the AP and as well as in the lateral view. Right, both AP and as well as the lateral view. And the confirmation can be done by the MRI of the spine. Confirmation is by the MRI of the spine, right? Then I said you mainly the involvement is the small joints. So after the involvement of the small joints, right, after the involvement of the small joints, in the later stages, you have the involvement of the large joints in case of the rheumatoid arthritis. So initially it is only small joints. Later you have the involvement of the large joints in patients with the rheumatoid arthritis. And you have to understand that nearly around 40% of patients with rheumatoid arthritis, they have the extra articular manifestations, right? Now, if you observe the extra-articular manifestations, I'll show you one important question. Which one of the following statements about the rheumatoid nodules is incorrect? The options are: rheumatoid nodules are typically tender when palpated, right? Second option, lung involvement can occur in association with the rheumatoid nodules. Pulmonary rheumatoid nodules can lead to exudative type of pleural effusion. Rheumatoid nodules can compress the peripheral nerves causing mononeuritis multiplex. Rheumatoid nodules on the median nerve can contribute to the development of the carpal tunnel syndrome. Now, you take these rheumatoid nodules, they are not tender on the palpation, right? They are not tender. So, these rheumatoid nodules, they are non-tender. And where is this rheumatoid nodules observed? These rheumatoid nodules, they are mainly observed over the extensor aspect of the forearm. Right, they are mainly observed over the extensor aspect of the forearm, right? And this particular rheumatoid nodules which are distributed over the extensor aspect of the forearm, these are considered as the most common extra-articular manifestations. Right, so these are considered as the most common extra-articular manifestations. That is about the the nodules, right? That is subcutaneous nodules. Then followed by that, you have the involvement of the lungs. So even in the lungs, you have the presence of the rheumatoid nodules, and the other respiratory manifestations will be in the form of interstitial lung disease, and these patients will also develop the pleural effusion. And the type of the pleural effusion that you will observe here is the exudative type of the pleural effusion. So in exudative type of pleural effusion, when you observe the pleural fluid glucose, that will be reduced. That is what you will observe even in case of rheumatoid arthritis also. And you take the ophthalmic involvement in rheumatoid arthritis, you have the development of episcleritis, right? And apart from this episcleritis, where you have the redness of the sclera, these individuals will also develop what is called as the 𝗏𝐺𝐻 syndrome. So, one of the important associated connective tissue disorder with the 𝗏𝐺𝐻 syndrome is rheumatoid arthritis, or rheumatoid arthritis is associated with the 𝗏𝐺𝐻 syndrome. This will be the ophthalmic involvement. Then, if you observe the involvement of the peripheral nerves, so the peripheral nerves that are very commonly affected is the median nerve, and that median nerve involvement is observed in the carpal tunnel syndrome, and you also have the involvement of the tibial nerve in case of the tarsal tunnel syndrome, right? So this is about the carpal tunnel syndrome and as well as tarsal tunnel syndrome, which are also the extra-articular manifestations in rheumatoid arthritis. Then you need to be aware of the cardiovascular system manifestations in the rheumatoid arthritis. If you take the cardiovascular system manifestations in rheumatoid arthritis, number one, these patients will develop the pericardial effusion. So as you have the pleural effusion in the lung, you have the pericardial effusion in the cardiac manifestations, and they also develop coronary artery disease. And what is the cause of death in patients with the rheumatoid arthritis is mainly because of the development of the coronary artery disease, right? Then followed by that, the next important manifestation that you will notice or that you will observe is that these patients will also develop valvular abnormality in the form of the MR, that is mitral regurgitation, right? Then these patients, why there is coronary artery disease? That is mainly because of the premature atherosclerosis that can contribute to the development of coronary artery disease and as well as the death of the individual, right? And about this important enthesitis, it is not the feature of the rheumatoid arthritis. Enthesitis, it is a feature of the seronegative arthritis like ankylosing spondylitis or the psoriatic arthritis. But this enthesitis, it is not observed in patients with the rheumatoid arthritis, right? So this is about the extra-articular manifestations. So going back to the question, so lung involvement can occur associated with rheumatoid nodules, correct? Pulmonary rheumatoid nodules can have exudative pleural effusion, correct. Mononeuritis multiplex, that is your carpal tunnel syndrome and tarsal tunnel syndrome, that is correct. And rheumatoid nodules can compress the median nerve, can contribute to carpal tunnel syndrome is also a correct statement, right? Then, if you see the next question, we have a 55-year-old male coal worker presents with the history of the joint pain, stiffness, and swelling in multiple joints, particularly in the hands and as well as wrist. He also reports a chronic cough, shortness of breath, and a history of working in coal mine for past 20 years. Chest X-ray reveals the presence of multiple rounded opacities in the lungs. What is the name of the syndrome associated with a combination of these symptoms? Goodpasture, Kaplan, Cushing syndrome, the Guillain-Barré syndrome. Okay, now, so these patients, they are having the features of the rheumatoid arthritis, where you have the stiffness of the joints, and along with that, the chest X-ray, you have the presence of multiple rounded opacities in the lungs, that we call it as the nodules. Okay, so these two together, we call this as the Kaplan syndrome. Right, so these two together, we call this as the Kaplan syndrome, right? So Kaplan syndrome is rheumatoid arthritis and as well as the coal workers pneumoconiosis, right? And we have one more syndrome that you need to know in case of rheumatoid arthritis, that is the Feltes syndrome. So what is in Feltes syndrome, you have a triad. What is a triad in Feltes syndrome is rheumatoid arthritis, then neutropenia, then splenomegaly, right? Then splenomegaly. Okay, so this is the Feltes syndrome in case of the rheumatoid arthritis. Then how is that you will, so this is like the X-ray in patients with the Kaplan syndrome, right, where you have the presence of the coal workers pneumoconiosis, that is the presence of the rheumatoid nodules, along with that you have the stiffness of the joints. Then how is that you will work up the patients with the rheumatoid arthritis is, number one, the RA factor will be positive, but RA factor, it is non-specific. So what is the investigation of choice? The investigation of choice will be anti-CCP, that is anti-cyclic citrullinated polypeptide. Okay, so that is what is the investigation of choice. Then when you do an arthrocentesis, you have the presence of the inflammatory cells. Right, so in arthrocentesis, you will notice that there is presence of the inflammatory cells, nearly around 5,000 to 50,000 cells, that is inflammatory cells per cubic millimeter, right? And the next important is about the X-ray. So when you do X-ray of the small joints, right, when you do an X-ray of the small joints, the X-ray of the small joints, you will notice that there is loss of the joint space, right? You will notice that there is loss of the joint space, and there is also periarticular osteopenia. Right, periarticular osteopenia. That is what you will observe in the X-ray of the joints, right? So this is about the workup in patients with the rheumatoid arthritis. And when you do an MRI of the joints will show you that there is presence of the synovitis. Right, there is presence of the synovitis. So that is about the workup in patients with the rheumatoid arthritis. Then, yeah, so this is like multi-system involvement that you will have in patients with the rheumatoid arthritis. So this image will give you all the systems which are affected in rheumatoid arthritis. Then, now coming on to the treatment in rheumatoid arthritis, we have a 45-year-old woman has been experiencing joint pain, stiffness, and swelling in her hands and feet for several months. She finds it challenging to perform her daily activities. Her rheumatologist suspects an autoimmune disorder and prescribes a medication that inhibits the enzyme dihydroorotate dehydrogenase. What drug could this be? The options are methotrexate, sulfasalazine, leflunomide, and as well as the hydroxychloroquine. So, in acute phase of the rheumatoid arthritis, the drugs that we give is the steroids, right? Plus or minus, we add the NSAIDs. right? Plus or minus, we add the supplementation of the NSAIDs. Whereas you take in case of the chronic cases of the rheumatoid arthritis. Okay, so in chronic cases of rheumatoid arthritis, the drugs that we give is the DMARDs, that is disease modifying anti-rheumatic drugs. And this disease modifying anti-rheumatic drugs, again we have two types, that is non-biologicals, right? And the second important group will be biologicals, right? The second important group will be the biologicals. Okay, now in the non-biologicals, what exactly will be the drug of choice that we start with? That is methotrexate. But if you take this methotrexate, it is a folate antagonist, right? This is a folate antagonist, right? Now, apart from methotrexate, the other drugs that are very much useful are hydroxychloroquine and then sulfasalazine, right? Hydroxychloroquine and sulfasalazine. And apart from that, we also have leflunomide. Okay. And when do we start these biologicals? That is the anti-TNF alpha. The biologicals we start when the individual is refractory to this non-biological DMARDs. And what is that molecule which is the drug, which is having the mechanism of action that will inhibit the dihydroorotate dehydrogenase is, that is the leflunomide. So leflunomide is a DMARD that will inhibit the dihydroorotate dehydrogenase, which is an enzyme which is responsible for de novo pyrimidine synthesis. Now, by inhibiting this particular enzyme, the leflunomide, it decreases, right? It decreases both T cell and as well as the B cell proliferation. It decreases both T cell and as well as the B cell proliferation. So thereby this leflunomide, it exhibits the immunosuppressive activity and it also has the anti-inflammatory effect, right? It exhibits the immunosuppressive and anti-inflammatory effect. Okay, so that is what is about the leflunomide. Now in the part of the treatment, right, in the course of the treatment, I'll show you one more question. We have a 50-year-old man with rheumatoid arthritis who started on methotrexate but shows limited response. Despite several weeks of the treatment, leflunomide is added but patient again fails to respond after several weeks. Which of the following medication is the likely to be prescribed next? The options are: try the same regimen, second adalimumab, third hydroxychloroquine, fourth sulfasalazine. So what you have to understand in the treatment is, methotrexate, it is considered as drug of choice. And how frequently we give methotrexate? We give once weekly, right? We give once weekly. And remaining 6 days, right? Remaining 6 days, we give the folate. Okay, we give folate supplementation or we give folinic acid. That is for remaining 6 days. And what is the important adverse effect which is associated with the methotrexate is bone marrow suppression. And this bone marrow suppression is the one which will be causing the pancytopenia, right? And the dose is around 5 to 20 milligrams per week, right? So that one tablet, whatever the patient is taking, either it should be like 5 or up to even 20 milligram, but it should be taken once a week. So on the day of the administration of the methotrexate, we don't give folate. The remaining 6 days, we give folate. Now, if the patient is not just responding only to the methotrexate, then the other drugs that can be added is the hydroxychloroquine and as well as the sulfasalazine can be added, right? Hydroxychloroquine and sulfasalazine has to be added. Now, if the patient does not respond to this triple therapy, so this we call it as triple therapy. If the patient does not respond to this triple therapy, then we start the patient on the biological DMARDs. And these biological DMARDs, they include the anti-TNF alpha or TNF alpha inhibitors. That is one regimen. The other one is, you give methotrexate, and if the patient is not responding only to the methotrexate, then the drug that you need to add is the leflunomide. Right? The drug that you need to add is the leflunomide. Now, with to this particular combination, if the patient does not respond, that is with methotrexate and as well as leflunomide, if the patient does not respond, that is also the point when we add the biological agents. Right, so that is also the point when we add the biological agents. Okay, so if you see this question here, the patient is on the methotrexate and along with that leflunomide has been added, but there is no still response. Then you need to add the biological DMARDs, and this particular biological DMARDs, one of the example here among the options which has been given is the adalimumab. That will be adalimumab, right? Now, apart from this adalimumab, right, we have many other molecules which are, what is adalimumab? It is TNF alpha antagonist, right? It is TNF alpha inhibitor, right? Now, whenever you are giving this adalimumab, one point you need to remember is this will suppress the immune system of the individual, and thereby these individuals, they are at increased risk of opportunistic infections like the tuberculosis. There can be increased risk of the bacterial infections. There can be increased risk of the fungal infections, and these patients, they also have increased risk of the viral infections, right? So that is when the immune system of the individual is being suppressed. And this particular adalimumab, it is not just prescribed only for the treatment of the rheumatoid arthritis. The adalimumab is also the drug which can be prescribed to many other autoimmune diseases or many other connective tissue disorders. This adalimumab is also used in the treatment of the psoriatic arthritis, right? And it is also used in the treatment of the ankylosing spondylitis. It is also used in the treatment of the ulcerative colitis. It is also used in the treatment of the Crohn's disease. And it is also used in the treatment of the plaque psoriasis. Okay, so these are all the multiple other conditions where this adalimumab can be used, right? And apart from this adalimumab, we have many other anti-TNF alpha antagonists, and we also give rituximab, which is an anti-CD20. Even that can be also given as a biological DMARD in the treatment of the rheumatoid arthritis. So this completes the discussion of the rheumatoid arthritis treatment, right? So with this, we are done with a quick revision of rheumatoid arthritis. And the next topic for the quick revision is the vasculitis. Now let me just revise the vasculitis. The question is, which of the following disease affects predominantly the large arteries? Granulomatosis with polyangiitis, then polyarteritis nodosa, then giant cell arteritis, and eosinophilic granulomatosis with polyangiitis. So, if you take the classification of the vasculitis, we classify them into the following. That is, the small vessel vasculitis, then medium vessel vasculitis, then large vessel vasculitis. So if you take the small vessel vasculitis, the examples of small vessel vasculitis will be Ħihnon-Schönlein purpura, then Churg-Strauss syndrome, next is microscopic polyangiitis, then Wegener's granulomatosis. So these are all the examples of the small vessel vasculitis. Whereas if you take the medium vessel vasculitis, the examples are the polyarteritis nodosa and then Berger's disease, right? And then followed by that Kawasaki disease, right? So these are the examples of the medium vessel vasculitis. The large vessel vasculitis, if you observe, that includes the Takayasu arthritis, right? So Takayasu arthritis, it is a large vessel vasculitis with age group less than 50 years. So in individuals with less than 50 years, you will have the Takayasu arthritis, which is a large vessel vasculitis. Whereas more than 50 years, if you take the large vessel vasculitis, that will be the giant cell arthritis. So giant cell arthritis, it is observed in age group more than 50 years. It is observed in age group more than 50 years. Okay, so this giant cell arthritis, this is also called as the temporal arthritis, right? Also called as temporal arthritis because the most common vessel that is being affected is the temporal artery, right? Now, so if you see the question, the answer is the giant cell arthritis. So granulomatosis with polyangiitis, that will be vaginous granulomatosis. This will be small vessel vasculitis. Polyarteritis nodosa, this will be the medium vessel vasculitis. Then eosinophilic granulomatosis with polyangiitis, this is 𝗠𝐞𝐝𝐢𝐬𝐷 syndrome, which is a small vessel vasculitis. Right? So one way by which we can classify the vasculitis is based on the size of the vessel, that is small vessel, medium vessel, and as well as the large vessel vasculitis, right? And the other way by which we can classify the vasculitis is based on the type of inflammation. So based on the type of inflammation, we classify the vasculitis as into two. One is the patients with granulomatous inflammation, and the other one is the non-granulomatous inflammation. Right, granulomatous and non-granulomatous inflammation. So if you take the vasculitis with the granulomatous inflammation, that includes Wegener's, that includes Takayasu arthritis, that includes the giant cell arthritis, and then the 𝗠𝐞𝐝𝐢𝐷 syndrome. So 𝗠𝐞𝐝𝐢𝐷 syndrome, it has both. There can be granulomatous inflammation and as well as non-granulomatous inflammation. So this non-granulomatous inflammation, this is also called as, or this will be necrotizing inflammation. And examples of this non-granulomatous vasculitis will be the remaining, that is polyarteritis nodosa, then microscopic polyangiitis, then even the 𝗠𝐞𝐝𝐢𝐷 syndrome. Even the 𝗠𝐞𝐝𝐢𝐷 syndrome. Okay, these are all the examples of the non-granulomatous inflammation or the necrotizing inflammation. Right. Then the next important method by which you can classify the vasculitis is based on the ANCA, right? That is anti-neutrophilic cytoplasmic antibody. Right. So we have two important forms of ANCA. One is the C-ANCA. The other one is P-ANCA. So C-ANCA, it is observed in case of the Wegener's, whereas P-ANCA in case of microscopic polyangiitis, also observed, right? Microscopic polyangiitis, and in some cases of SLE also you can have this P-ANCA, right? That is, P stands for perinuclear, right? And C stands for cytoplasmic ANCA. And the other way by which we can classify the vasculitis is based on age group. The most common form of vasculitis in children, right? Most common form of vasculitis in children, that will be Ħīnān-Schönlein purpura, and followed by that Kawasaki disease, right? Followed by that Kawasaki's disease, right? Then the most common form of vasculitis in adults, that will be Takayasu arthritis, right? That will be Takayasu arthritis. So this will be the various methods by which we can classify the vasculitis. Now, right, we'll do few more questions on the various types of the vasculitis. We have a 70-year-old man presents to the clinic due to stiffness and pain in his shoulder and hips for the past few weeks. He feels fatigued and has low-grade fever and also complains of persistent throbbing, right-sided headache and jaw pain. On physical examination, a nodular swelling along the temporal artery is noted. An histopathological examination imaging from his temporal artery biopsy is shown. What is the treatment of choice? The options are non-steroidal anti-inflammatory drugs, high-dose glucocorticoids, disease-modifying anti-rheumatic drugs, then acetaminophen, which is nothing but the paracetamol. Okay, right. So if you observe what is the treatment of, first of all, what is the type of vasculitis here? So the vasculitis that you will observe, that too in a 70-year-old male, right? That too in a 70-year-old male with stiffness and pain within the shoulders and hip, and the persistent throbbing pain and over the right side of the head, and there will be jaw pain also. All these are features suggestive of giant cell arthritis or the temporal arthritis. right? Giant cell arteritis or the temporal arteritis. So giant cell arteritis or temporal arteritis is the one which is usually observed of age group more than 50 years. And the most common vessel that will be affected is the temporal artery, right? And these patients, the temporal artery is like inflamed. They will have headache. And that is because of the inflammation of the temporal artery. And there will be tenderness over the temporal artery, right? And age group already I have said more than 50 years, and the type of inflammation, granulomatous inflammation. And the temporal artery is also the one which will be supplying to the muscles of mastication. That is the reason why they complain of the jaw pain, that is jaw claudication. So that means these patients, after chewing for a certain period of time, they'll have severe pain within the jaw. That is what is called the jaw claudication, right? And the next important is, if you observe what is the most feared complication in giant cell arteritis, the most feared complication in giant cell arteritis is the development of the blindness. And this blindness, it is mainly due to the involvement of the posterior ciliary branch of the ophthalmic artery, right? So due to the involvement of the posterior ciliary branch of the ophthalmic artery, there will be development of blindness, and that too a sudden onset blindness. That too a sudden onset blindness. Okay. Then the next important point here is, 40% of these patients develop polymyalgia rheumatica. They develop polymyalgia rheumatica. So polymyalgia rheumatica, it is the stiffness of, right, the stiffness of the shoulder and as well as the hip girdle, right? The stiffness of the shoulder and as well as the hip girdle. That is what is called the polymyalgia rheumatica. And shoulder girdle stiffness will be more than compared to that of the hip girdle stiffness. And that is what is called as the polymyalgia rheumatica, right? Then followed by these two important manifestations. So you have the manifestations due to the involvement of the ophthalmic artery, due to the involvement of temporal artery, and as well as the polymyalgia rheumatica. And the next important is, you need to know the investigation of choice. That will be the temporal artery biopsy. But whenever you are taking this temporal artery biopsy, you need to take the biopsy of almost up to 2 centimeters. Why? Because in case of giant cell arteritis, the inflammation is not continuous. It is like segmental inflammation is what you will observe, right? The inflammation is like skipped inflammation. So that is the reason why you need to take the biopsy of a longer vessel, so that this biopsy will demonstrate the presence of the granulomatous inflammation, right? Then what exactly is the treatment? So the drug of choice in these individuals is, you need to give high dose steroids, right? You need to give high dose steroids. That is considered as the drug of choice which will reduce the inflammation, right? And polymyalgia rheumatica, even this polymyalgia rheumatica also gets reduced whenever you give this particular steroids. And what is that steroid that we give? That is the prednisolone. And the dosage of the prednisolone that you will be giving in giant cell arteritis is around 40 to 60 milligrams per day. And this 40 to 60 milligrams per day that you are giving, that should be given for almost 1 month, right? And then gradually you need to taper and then stop. So that is about the dosage of the steroids. And the NSAIDs, if you observe, the NSAIDs, they are commonly used to relieve the pain, right? And that is not the treatment of choice in case of the temporal arteritis or giant cell arteritis. And next is DMARD, disease modifying anti-rheumatic drugs. They are typically used in the treatment of autoimmune diseases like the rheumatoid arthritis, okay? But not in case of the giant cell arteritis. Next is paracetamol, that is acetaminophen. So this is an analgesic and antipyretic medication, and that is commonly used for the treatment of fever and as well as pain, but not the treatment of choice for the temporal arteritis. Okay, so this completes the discussion of one of the important large vessel vasculitis, that is the temporal arteritis or giant cell arteritis. Then you take the next important form of vasculitis. A 10-year-old child presents with red raised rash on the buttocks and as well as legs. The mother reports that the child also has the joint pain, abdominal pain and fresh blood in the stool yesterday. Laboratory investigations revealed elevated levels of the IgA. What is the most likely diagnosis? The options are the 𝗉𝐻𝐻𝐿𝑖N's purpura, idiopathic thrombocytopenic purpura, amyloidosis, and then the 𝗏𝐺𝐻 disease. So, child, there is rash, joint pain, abdominal pain, elevated IgA levels. All these are suggestive of the 𝗉𝐻𝐻𝐿iN's purpura. So the child exhibit classical signs and symptoms of the 𝗉𝐻𝐻𝐿iN's purpura. And another name for 𝗉𝐻𝐻𝐿iN's purpura is, this is also called as the IgA vasculitis, because within the vessel, the antibody that you have is the IgA, which is a complex immune mediated vasculitis, right? And that mainly involves the small blood vessels. And these patients with 𝗉𝐻𝐻𝐿iN's purpura, they are characterized by a tetrad, right? And what will be the tetrad? You just remember this mnemonic, that is HSP. H stands for hematuria. And that is because of the development of the glomerulonephritis. And over the skin, you have the development of the purpura. But the purpura here that you will have is not because of thrombocytopenia. In these individuals, in fact, there will be thrombocytosis. Right? In fact, these patients will have thrombocytosis. Right? Thrombocytopenia will not be there. Then why is that you have this purpura? That is because of the cutaneous vasculitis. That is because of the cutaneous vasculitis you have the presence of the purpura, right? And this purpura, they are mainly distributed over the lower limbs. The purpura, it is mainly distributed over the buttocks. The purpura, it is mainly distributed over the abdomen, right? That is the skin manifestations. And lastly, the P. P stands for pain, right? So pain in the abdomen and as well as in the joints, right? Pain in the abdomen and as well as the joints. So this is a tetrad: hematuria, skin manifestations, then the pain in the abdomen and as well as within the joints, right? And one point you need to know is, these patients, they can have anemia, and that is because of the chronic inflammation. Then what is the other part of the workup? The other part of the workup is biopsy. Investigation of choice will be the skin biopsy. And when you do a skin biopsy, you will notice that there is presence of IgA vasculitis, right? Or this we call it as leukocytoclastic vasculitis, right? Leukocytoclastic vasculitis, where you have the presence of IgA within the blood vessels. That is the investigation of choice. Then drug of choice, if you observe, that includes corticosteroids, that is prednisolone. So prednisolone is considered as the drug of choice, right? Now, if you take the diagnostic criteria, there are totally 4 important diagnostic criteria. So 2 out of 4 should be positive, right? 2 out of 4 should be positive. Number 1 is palpable purpura, right? Palpable purpura, number 1, right? Number 2, the angina, that is intestinal angina, right? Number 3, so intestinal angina or bowel angina. Next, biopsy, it should be able to demonstrate the presence of the IgA, right? And the age group, commonly it is pediatric age group. It can be observed in young adults also, but commonly in the pediatric age group of less than 20 years. So out of these 4, 2 should be there to consider it as the 𝗉𝐻𝐻𝐿iN's purpura, right? So that is about the important small vessel vasculitis, that is HSP. And in the biopsy, it is IgA, and even the complement C3 is also deposited within the blood vessels. And this particular C3 and as well as the IgA deposition can be demonstrated by the immunofluorescent microscopy. That can be demonstrated by the immunofluorescent microscopy, right? So that is about the story of your HSP, 𝗉𝐻𝐻𝐿iN's purpura. Then, coming on to the next question. We have a 6-year-old child presents with sore throat, fever and skin rash. Oral examination shows erythematous enlarged tonsils. the skin rash is a blanching papular rash that lacks the confluence. Which of the following is the most likely diagnosis in this scenario? Scarlet fever, Kawasaki disease, measles, hand, foot, mouth disease. So the answer here is the scarlet fever. Okay, so the rash which has been described in the clinical scenario, that is erythematous rash, which is like blanching papular rash that lacks the confluence, that is very much suggestive of the rash of the scarlet fever, right? And the rash in scarlet fever, it is usually associated with the bacterial pharyngitis, right? Usually associated with bacterial pharyngitis. Okay, and the scarlet fever usually it is observed in school aged children and as well as the adolescent children, right? And this blanching rash, which is erythematous papular, that is being described as the sandpaper rash, right? That is being described as the sandpaper rash, and the lack of the confluence of the lesion is the primary reason it feels like the sandpaper. It feels like the sandpaper. And what is the common organism that will be causing this scarlet fever? That is the Streptococcus pyogenes. Right, the Streptococcus pyogenes, that too Streptococcus pyogenes group A, right? So this is the causative bacteria for the development of the scarlet fever. Then what will be the other features in case of the scarlet fever is the presence of lines called as the Pastia lines. And the Pastia lines, they are observed over the flexural areas, right? Observed over the flexural areas with mild desquamation. And along with that, these patients will have the strawberry tongue, and this particular strawberry tongue, it is like red color. Okay, red strawberry tongue. And where is it you have white strawberry tongue? That is observed in case of the Kawasaki disease. And apart from that, these patients will also have the circumoral pallor, right? Circumoral pallor. And cervical lymphadenopathy will be there, where you will have bilateral cervical lymphadenopathy is observed. And what is the treatment that you will be giving in these individuals? The treatment that we'll be giving is the ampicillin in case of the Streptococcus pyogenes. Then you take the other options like Kawasaki disease. So the Kawasaki, it can present with rash and fever, but this Kawasaki, it is usually associated with a very high grade fever, and the duration of the fever also, it should be more than 5 days. And in Kawasaki, you will have a high grade fever, and there will be also the swollen lymph nodes. And the swollen lymph nodes, it is not bilateral, it is unilateral cervical lymphadenopathy, right? And in case of the Kawasaki, the color of the strawberry tongue, it will be pale, right? Or white strawberry tongue. Whereas in scarlet fever, it is red strawberry tongue, right? So that is about the Kawasaki. Whereas you take measles, they present with characteristic maculopapular rash that typically starts on the face and then it spreads to the rest of the body. And a sore throat and enlarged tonsils can also be present, but the sandpaper like rash which is described in this scenario, it is not observed in case of measles. So that is the reason why the measles are ruled out. And what exactly is this hand, foot, mouth disease? Hand, foot, mouth disease, it is characterized by rash on the hands and as well as feet and even inside the mouth. Okay, sore throat and fever can be there in hand, foot, mouth disease, but the sandpaper like rash and enlarged tonsils which has been described in this scenario is not typical for the hand, foot, mouth disease. Okay, so that is about the description related to the scarlet fever which is caused by the Streptococcus pyogenes, right? Then we will talk about the differential diagnosis. You see this question. A 3-year-old child is brought to the pediatric clinic with the high fever for the past 5 days. his parents noticed redness in the child's eyes and a rash on the body. On examination, the physician observes unilateral lymphadenopathy in lymph node enlargement in the cervical region. The child's tongue appears to have distinct appearance. What is the most likely diagnosis for this child's condition? Scarlet fever, Kawasaki disease, measles, and then rubella. So the entire clinical picture is suggestive of the Kawasaki. Now let me just quickly revise about the Kawasaki. So Kawasaki, the another name for this is also called as mucocutaneous lymph node syndrome. Right, so this is also called mucocutaneous lymph node syndrome. And the clinical scenario is consistent with Kawasaki here. It is a medium vessel vasculitis primarily affecting the young children of age group less than 5 years. Whereas 𝐒𝐻𝐈n's purpura of age group are even up to 20 years, but Kawasaki most commonly up to age of the 5 years. So there are 5 important criteria in Kawasaki. Out of 5, there should be 4. So one is definitely there should be fever. That should be there for more than 5 days. Along with fever, there should be 5 criteria. What is that? Just remember this mnemonic, that is cream. Right? So the word C stands for conjunctivitis. Right? And the word R is rash. The word E is edema. The word A is adenopathy. Right, and that too, a unilateral cervical lymphadenopathy is common, whereas in scarlet fever it is bilateral, but here it is unilateral, and that too the lymphadenopathy is observed in the cervical region. And M stands for the mucosal involvement, and that mucosal involvement will be in the form of the strawberry tongue, and the tongue that is observed in Kawasaki, it will be usually a pale or white strawberry. Red strawberry is observed in the scarlet fever. And the most common vessel that is affected here is the coronary artery, where there will be coronary artery aneurysms, and that is the reason why you need to do a 2D echo in order to check for how is the LV function in these patients, right? And what is the treatment? The drug of choice that you will have in patients with the Kawasaki disease will be the intravenous immunoglobulin should be given, and this intravenous immunoglobulin that should be given at a dosage of 2 grams per kg, right? 2 grams per kg as a single infusion over 10 hours. And along with that, you need to add the aspirin, that is mainly to prevent the coronary artery thrombosis. And if there is the development of the thrombus, right? If there is development of the thrombus where there is complete blockade of the coronary artery, then you need to do thrombolysis with the tissue plasminogen activator. So this is in brief about the Kawasaki. So complications with Kawasaki will be the coronary microaneurysms. Apart from that, pericarditis, myocarditis, myocardial ischemia and infarction, and cardiomegaly. So these are the complications. Okay, and you take the incorrect options, like you take the scarlet fever. Scarlet fever is caused by group A streptococcus bacteria, just now we have discussed, and typically this will present with sandpaper like rash, fever and sore throat. And you will have a strawberry tongue in scarlet fever, but it will be a red strawberry tongue, right? And this strawberry tongue, it is not specific in scarlet fever, but it is very much specific in case of the Kawasaki. Then you take, so your scarlet fever ruled out. Then measles. Measles is caused by the measles virus, characterized by high fever, cough, coryza, conjunctivitis, and a characteristic maculopapular rash that starts on the face and spread downwards. That is what you will observe in case of the measles. Then how is that you will rule out the rubella or the German measles? Rubella is caused by the rubella virus, and it is usually a milder infection compared to that of the measles. And this particular rubella, it presents with a rash that starts on the face and then spreads on to the trunk and the extremities. So that is what is your rubella, which is nothing but the German measles, right? So this is an important table of Kawasaki, which is also called mucocutaneous lymph node syndrome. The common age of presentation is less than 5 years, and they'll have fever, right? Along with fever, they have 5 important manifestations. 4 out of 5 should be positive, and the drug of choice is IVIG, and along with that you need to give aspirin. And these are the important differences between Kawasaki and as well as the scarlet fever. So the fever duration, if you observe in Kawasaki, definitely it should be more than 5 days, and it is less than 4 days in case of the scarlet fever. Then mucocutaneous lymph node syndrome, it is present only in Kawasaki but not in scarlet. Strawberry tongue present in both, and bulbar congestion, periungual peeling, perianal peeling, these 3 seen in Kawasaki but not in the scarlet. Scarlet rash and pastia lines present in scarlet but not in Kawasaki. Lymphadenopathy, unilateral cervical lymphadenopathy is observed in Kawasaki, bilateral cervical lymphadenopathy in scarlet. So this is about your Kawasaki disease, right? Next. So Kawasaki is what? It's a medium vessel vasculitis. Next question. A 22-year-old female from India present with symptoms of the arm claudication and significant difference in the blood pressure between her right and left arm. On further evaluation, she is found to have the renal artery stenosis. Which of the following is the most likely diagnosis in this patient? Atherosclerosis of the renal artery, fibromuscular dysplasia, Takayasu arthritis, and then the coarctation of the aorta. So the answer here is the Takayasu. Now let me discuss about the Takayasu arthritis. So Takayasu arthritis, this is also the large vessel vasculitis, and this is commonly observed of age group less than 50 years, right? And in this scenario, very important clue here is the limb claudication and as well as difference in the blood pressure between the 2 upper limbs. And among the options which has been given to you, even in coarctation of aorta also, you can have difference in the blood pressure between the 2 upper limbs if the coarctation, if it is present proximal to the left subclavian artery, right? If the coarctation is present proximal to the left subclavian artery, then you can have difference in the blood pressure between the 2 upper limbs. But this coarctation of aorta, it is a congenital disorder usually observed in the children, but here if you observe, the age of the individual is 22 years. And in case of the Takayasu arthritis, why is that you have the claudication pain is, in Takayasu arthritis the most common vessel that is affected is left subclavian artery. So left subclavian artery is inflamed, so thereby the blood supply to the left arm, it is being reduced, right? Blood supply to the left arm, it is reduced. So once the blood supply to the left arm is reduced, these individuals, they'll have what is called the claudication pain. These individuals, they'll have the claudication pain, okay? And not only that, if you observe the pulse in the left upper limb, right? So you will have the feeble pulse or completely absent pulse. And that is the reason why this is called as a pulseless disease. That is why it is called pulseless disease. And because there is no blood supply to that particular limb, these patients, they complain of the arm claudication. Right? These patients, they complain of the arm claudication, right? Pain in the arms, right? And along with that, these individuals, they'll also have the fever and as well as the night sweats. They also have arthritis and then the myalgia, and there will be also the skin nodules, right? There will be also skin nodules and there will be also ocular disturbances as well. And what exactly is the investigation of choice in case of the Takayasu arthritis is the MR angiography, right? So MR angiography is the investigation of choice, and it will also help in staging the disease distribution, right? And MR angiography, definitely it's a time taking, right? But in acute situations like where you have the involvement of the coronary arteries, you cannot do MR, where you can do a CT angiography, right? So in emergency situations, CT angiography can also be done. Then what is the treatment? The treatment in case of the Takayasu, it is the corticosteroids, okay? Corticosteroids. That is prednisolone has to be given. And some patients, they will be requiring surgical revascularization. Some patients, they will be requiring surgical revascularization. So that is about your Takayasu arthritis. So you take the other options, atherosclerosis of the renal artery. Atherosclerosis of the renal artery, it is commonly observed in older individuals, not in a 22-year-old female. And when there is atherosclerosis of the renal artery, the risk factor that you need to know is the smoking. So most of the times there will be smoking history, like if you are observing that there is atherosclerosis within the renal artery. And once there is atherosclerosis of the renal artery, there will be decreased renal perfusion causing the excessive activation of RAS, and these patients will have the hypertension. Then fibromuscular dysplasia. So fibromuscular dysplasia is another cause of the renal artery stenosis, and that is commonly observed in the young individuals. Right? Fibromuscular dysplasia is another cause of renal artery stenosis, typically seen in young females. And this is characterized by abnormal cell growth in the arterial wall. Right? And this abnormal cell growth in the arterial wall will lead to the narrowing of the vessel. Right? Will lead to narrowing of the vessel. And even your fibromuscular dysplasia is also one of the cause for renal artery stenosis, where there will be activation of RAS causing hypertension. And coarctation of aorta, as just now we have discussed. Right? So this is about the Takayasu arthritis, which is a large vessel vasculitis. And one of the very important medium vessel vasculitis is polyarteritis nodosa. The vessel commonly affected here is the renal vessels, but glomerulonephritis is not observed in case of the polyarteritis nodosa. And vessels that is never affected in case of polyarteritis nodosa is pulmonary circulation. That will never be affected. And the viral markers, if you observe, that is the hepatitis B surface antigen will be positive. That will be the viral markers. And because the polyarteritis nodosa, it is usually associated with the hepatitis B virus. And when you do a microscopic examination or histological examination, you will notice that there is fibrinoid necrosis. And this fibrinoid necrosis will be segmental and as well as the transmural. That is what is your polyarteritis nodosa. Right? Then followed by that, the next important form of vasculitis. A 30-year-old female presents with recurrent episodes of epistaxis, sinusitis and nasal ulcers. She also complains of hematuria and has lung lesions in the form of multiple cavities on the chest imaging. Laboratory test reveals the presence of the 𝐒𝐮𝐬𝐜𝐫 antibodies. Which of the following is the most likely diagnosis? Granulomatosis with polyangiitis, microscopic polyangiitis, polyarteritis nodosa, and then the Churg-Strauss syndrome. So the presence of the 𝐒𝐮𝐬𝐜, it is considered as the investigation of choice for the Wegener's granulomatosis, which is also called granulomatosis with polyangiitis. And this Wegener's granulomatosis, this is characterized by a triad. And what is a triad in Wegener's granulomatosis? That includes upper respiratory tract involvement, that includes lower respiratory tract involvement, and that also includes the involvement of the kidney. So you take the upper respiratory tract involvement. The upper respiratory tract involvement, you will have the manifestations in the form of epistaxis. There can be also development of the sinusitis. There will be also nasal and as well as the tracheal ulceration, right? That will be upper respiratory tract involvement. Lower respiratory tract involvement will be in the form of the cavity formation within the lung, right? So there will be cavitary lung lesions. And the kidney involvement will be in the form of the hematuria, and that is due to the glomerulonephritis. And the antibodies, that will be the 𝐒𝐮𝐬𝐜. And please remember, 𝐒𝐮𝐬𝐜, it is the antibody which is directed against the proteinase 3. Right, which is directed against the proteinase 3. And the treatment that you will observe in case of the Wegener's, you need to give the corticosteroids. And one more, when you do a biopsy in these patients with the Wegener's, the type of the inflammation will be the granulomatous inflammation. Right, the type of inflammation will be granulomatous inflammation, and the treatment will be the steroids, and these steroids should be given in combination with either rituximab, right, or the cyclophosphamide. Right, rituximab or the cyclophosphamide. Okay, so that is what is the treatment in case of the Wegener's granulomatosis. And you take the other option, that is microscopic polyangiitis. Microscopic polyangiitis, primarily it affects the small blood vessels, right? Small blood vessels, including the glomerular capillaries, right? Including the glomerular capillaries. And this microscopic polyangiitis, it is not associated with sinusitis, nasal ulcers and lung cavities. So microscopic polyangiitis is ruled out. And polyarteritis nodosa, it affects the medium-sized vessels, and it is not associated with the upper respiratory tract involvement. Upper respiratory tract involvement is not the feature of the polyarteritis nodosa. And in polyarteritis nodosa, you don't have the 𝐒𝐮𝐬𝐜𝐫 as well. Then you take the 𝗠𝐞𝐻-Strauss syndrome. So 𝗠𝐞𝐻-Strauss syndrome, what will be the clinical manifestations is, very important is asthma. Asthma will be very important feature in case of the 𝗠𝐞𝐻-Strauss, right? And along with that, you will notice that there is eosinophilia and systemic vasculitis, right? So here you will have both upper respiratory and as well as lower respiratory tract involvement, right? But the presence of the nasal ulcers, right? The presence of the nasal ulcers, they are not observed in case of the 𝗠𝐞𝐻-Strauss syndrome, right? And even the chest X-ray showing multiple cavities, they are not observed in case of the 𝗠𝐞𝐻-Strauss syndrome, right? And in patients with the 𝗠𝐞𝐻-Strauss, you have the presence of the 𝐮𝐸𝐼, and that will be the 𝑃-𝐮𝐸𝐼. So 𝑃-𝐮𝐸𝐼 will be positive in case of the 𝗠𝐞𝐻-Strauss syndrome, right? So that is about the 𝗠𝐞-Strauss and as well as the vaginous granulomatosis. So in vaginous granulomatosis, you have 𝐶-𝐮𝐸𝐼, which is directed against the proteinase 3, right? Whereas you take the 𝑃-𝐮𝐸𝐼. In microscopic polyangiitis, you have 𝑃-𝐮𝐸𝐼. The 𝑃-𝐮𝐸𝐼, it is directed against MPO, myeloperoxidase antibodies, right? And we have one more form of vaginous, that is limited vaginous granulomatosis. What do you mean by the word limited? Actually, you have a triad in vaginous, that is upper respiratory, lower respiratory and the kidney involvement. But limited vaginous granulomatosis is that where you have the involvement of lungs only, and this we call it as lung limited, right? So this we call it as lung limited granulomatosis with polyangiitis. That is what is your limited vaginous granulomatosis, right? So this finishes about your vaginous. So with this we are done with, and one more important question on the vasculitis. A 30-year-old male patient presents with recurrent painful oral aphthous ulcers, scrotal ulcers and hypophion in the eye. Upon further evaluation, the patient is found to have the HLA-B5 positive. Which of the following is the most likely diagnosis? The options are Behçet's, Crohn's, herpes simplex virus infection and as well as the SLE. So this clinical scenario is suggestive of the Behçet's disease. Behçet's, it is the disorder which is characterized by, right, which is characterized by recurrent painful oral aphthous ulcers. Okay, that is what you will observe in case of the Behçet's, and along with that you have scrotal ulcers and as well as hypophion, and HLA-B5 will be positive, and that is highly suggestive of the Behçet's. And this Behçet's, it is very commonly observed in countries like Turkey, China, Arab countries and as well as Mongolia. And what will be the features in Behçet's? The pathognomic manifestation is recurrent painful oral aphthous stomatitis. And along with that, these patients, they will also have genital ulcers, that is vulval ulcers in case of females, and scrotal ulcers in males, and hypophion, that will be the ocular manifestations. And the workup that you will do in Behçet's is the positive pathogy test, then HLA-B5 will be positive. And the arteries commonly involved are pulmonary arteries that can cause pulmonary artery vasculitis and pulmonary hypertension. And the blood-brain barrier vessels are commonly affected. And the treatment will be the topical steroids and IV methylprednisolone and as well as the azathioprine. So this will be the treatment in case of the Behçet's. This will be the treatment in case of Behçet's. So this completes the discussion of the vasculitis. So this is about the important topics of the discussion for the UPSC related to the connective tissue disorders in the general medicine. Thank you very much.